Now, let's talk a bit about treatment options. And you can roughly divide these into two major venues of treatment. One I'll call rate control, and the other we'll call rhythm control. And for simplicity, we're going to talk about the rate control options first. In reality, sometimes we do a little of both at the same time. But just to review the different ideas, we'll start with rate control. So remember that the three problems when people go into A-Fib is they lose their priming pump, they have faster than normal heart rates, and their heart rate is irregular. And we're talking about how fast the bottom chamber goes in terms of these two issues. One strategy, which is pretty simple and pretty straightforward, is to just basically try to slow the heart rate down. So when we do that, we usually give people medicines. And there's several different classes of medicines that we can utilize. The most commonly used one is a beta blocker. And some familiar names for beta blockers include toprol or metoprolol, atenolol, nadolol, pindolol. If it ends in an -ol, it's probably a beta blocker. What these medicines do is they blunt some of the nervous input to the heart. Picture the heart is this very richly innervated organ. You know when you exercise, your heart rate normally goes up. When you're asleep or resting, your heart rate comes down. That's all mediated by the nervous input to the heart. These beta blockers effectively blunt some of that nervous input to the heart and dampen how fast those signals can get from the top part of the heart to the bottom part of the heart through that skinny little connector in the middle. And there's a dose-dependent effect. So if folks go into A-Fib and they're not on any beta blockers, their heart rates may be 140 to 160. If we put them on a small dose of beta blocker, their heart rate may go down to about 120. If we put them on a moderate dose, we might be down to 100 to 110. And if we put them on a robust dose, it may be down to 80 to 90. It has to be individualized to the person, but the idea is usually we can achieve some reasonable degree of heart rate control by titrating these beta blockers appropriately. Some of the limits of these medicines are that if you go in and out of A-Fib, these medicines slow your heart rate when you're in normal rhythm as well, and they also tend to lower the blood pressure. So it may work very well to control your heart rates when you're in A-Fib, but if you then pop back into normal rhythm, your heart rate may be particularly slow, and people may not feel well with an excessively slow heart rate in normal rhythm, although it works pretty well to control their fast heart rates when they're in A-Fib. Likewise, sometimes it can lower the blood pressure to the point where, although we achieve adequate heart rate control, their blood pressure is so low that they start to feel lightheaded and woozy when they stand up or try and do things. So it's ideal when we can find a dose of beta blocker that adequately controls heart rates without excessively overshooting and having too slow heart rates or having excessively low blood pressures. Sometimes we can dial that in, sometimes we can't, but we usually try. There are other classes of medicines that work through a similar idea as these beta blockers. One's called a calcium channel blocker. Common medicines in that group include diltiazem or verapamil. And a third class, which is sort of an old-fashioned class and works best at people who aren't particularly active, is digoxin. So people may be on 1, 2, or 3 of these medicines in an attempt to try to manage their heart rates when they're in A-Fib. If their heart rates tend to go too slow when they're in normal rhythm, sometimes we actually have to put a pacemaker in folks in order to support their lower heart rate and then allow the continued use of these heart rate slowing medicines to rein in the fast heart rates. So if you picture the heart rate spectrum from very slow to very fast, normally people live in the middle. When you go into A-Fib, you're up here in the faster heart rate range. We put you on medicines to try and slow you down. There may be some degree of overshoot where people then tend to go too slow at other times, and we use a pacer to prop up the lower heart rate, and between the pacer and the meds, keep you in the happy middle ground, hopefully free of symptoms. Now, there is another approach for heart rate control that I'll introduce here, but is typically not the first-line therapy that we choose. I introduce it here because it kind of fits with this heart rate control idea, but it's usually our option of last resort. And that involves an AV node ablation. What we do is I put a skinny little catheter up through the groin, and I can park the tip of this catheter right on that skinny little connector that joins the top and bottom chamber of the heart. That's called the AV node, that phone line, if you will. The A stands for atrium, V stands for ventricle, node just means group of cells, and it's essentially the waist of the hourglass electrically. I can put my catheter right on this thing and deliver a little electrical signal through this catheter that cauterizes it and basically takes out the phone line. That electrically divorces the top chamber of the heart from the bottom chamber of the heart and intentionally creates a condition known as heart block. Now, that works well in terms of trying to keep the top chamber of the heart from making the bottom chamber go fast and irregular, but there are some caveats. The benefits are that you don't need any medicines then to slow your heart rate down and wouldn't have any extra lowering of your blood pressure. So it simplifies heart rate control, but the bottom chamber of the heart left on its own is kind of a dumb chamber, and it typically doesn't know what to do on its own. It will beat, but typically very, very slowly and unreliably. And you would feel terrible if you had a heart rate of 20 and pauses of varying seconds in duration at times. So we have to put a pacemaker in those folks. And logistically, what we would typically do is put the pacemaker in first, make sure it's pre-installed, there's no issues or problems with the pacemaker, and once we're satisfied with that, come back and do the AV node ablation, which then would leave you pacemaker dependent for the rest of your life. It doesn't fix the A-Fib. You still may have A-Fib, but the idea is the bottom part of your heart would be governed entirely by the pacemaker at an even and regular cadence. And you wouldn't feel any of the palpitations or fast heart rates or need any of the medicines to slow your heart rate down. So the advantages of this strategy are that it works exceedingly well. It's, of all the options, perhaps the most reliable way to make the symptoms of A-Fib, not the A-Fib itself, but the symptoms of A-Fib go away. Virtually 100% success rate. And sometimes that's what we're after. It also eliminates, to a large degree, the medicines you might otherwise need for managing your heart rates in A-Fib. Some folks still have high blood pressure and need to be on blood pressure medicines, but we may not need to use such robust doses of these heart rate controlling medicines otherwise to control your heart rate. Now, the drawbacks to that approach are, number one, you need a pacemaker, which, although is a minor surgical procedure, is a procedure nonetheless. Takes about an hour to put a pacemaker in. The pacemaker runs on batteries. The batteries are very sophisticated. They last a long time, but not forever. Usually a pacemaker will last about 8 to 10 years, and then the little disc under the skin here needs to be replaced. That's about a 30-minute procedure once a decade. You are dependent on the pacemaker for every heartbeat for the rest of your life. Some people have more or less of a psychological barrier with that idea. There are lots of people out there who are pacemaker dependent and you'd never know it and they never feel it, but sometimes that's an insurmountable psychological barrier for some folks. When you pace the heart, your EKG appears different. So, for example, sometimes when people come into the emergency room having chest pain, we do an EKG on them to see if they're having a heart attack. If you're paced all the time, your EKG appears different, and that would no longer be available to interpret in terms of whether you're having a heart attack or not. There are other ways we can try and determine that, but reviewing your EKG, which is typically one of the first things we do for chest pain patients, we wouldn't be able to interpret that with regard to if you're having a heart attack or not. And the last is that when we artificially pace the heart, it's not quite as efficient as if the heart uses its own normal electrical distribution system. We create a little bit of an electrical wobble in the activation of the bottom chamber, and that does compromise the heart's pumping function a small degree. Typically, this is not perceptible for people who start off with normal heart pump function. But if you had a compromised heart pump function, say from prior heart attacks or other heart disease, a small drop in pumping function based on pacing the heart may cause enough trouble that you might have symptoms from it. There are some other pacing options that, if that's your case, we would get into in more detail that are a workaround for that strategy. So the big ideas here in terms of rate control are we have medicines that work for rate control, and in general they work pretty well, some limitations. We have procedures, pacemaker and AV node ablation, that work really well for heart rate control, but have some concessions in terms of that option.